Next up, we have Andrew McCarty. Andrew is the founder of Clover Genetics and a board-certified genetic counselor with a strong focus on expanding access to genetic care through telehealth. Mr. McCarty has supported patients across pediatrics, oncology, and neuromuscular conditions, including RYR1-related diseases. It's an honor to have him here today to share his expertise with the RYR1-RD community through his presentation, Interpreting Your Genetic Results, which will help us better understand what genetic findings mean and how they can inform care and decision-making.
Bear with me 1 second, just trying to get my notes up here. All right, well, hello everyone, and thank you again for the introduction. To start, I have no conflicts to disclose. As noted, my goal today is really to present on the different ways genetic testing results can be reported, what those results mean, and we'll start by reviewing some basic genetic terms. And let me see if I can get this out of here too as well. One moment, just need to go into my settings to fix this. That's better, sorry about that. So we'll start by reviewing some of the basic genetic terms. We'll talk about pathogenic, likely pathogenic, uncertain significance, and benign, likely benign. And finally, we'll review some of the implications of this data and how it can impact diagnosis, management, and family planning. So first, in terms of key learning objectives, it's important to have the context of what the concepts of variant, pathogenicity, and inheritance mean to understand how they play into result interpretation. Next, we'll review how test reports and variants are classified using a framework developed by the American College of Medical Genetics and the Association for Molecular Pathology. And then lastly, we'll review how each of these results can impact care, direct management, and impact counseling for other family members as well. So to start, I'd like to review a few terms just to make sure we're speaking the same language. Likely, these have been reviewed a little bit in my previous presenters' slides, but just to make sure we're on the same page. When we're considering genes, what we're speaking about is a succinct instruction manual for each cell that ultimately encodes a protein that then provides a function in the body. So as been reviewed, essentially each person has 2 copies of most genes, one from each parent, with the exclusion of the sex chromosomes. A variant is simply a change in one of these gene copies, either at a single point or more broadly, that can be as a deletion or a duplication. By analogy, which has been reviewed previous, if you think of a gene as an instruction manual for making a protein, a variant is essentially a typo in that. Some typos don't change the meaning. Typically, those are referred to as benign, or that normal variation we all have. Some modify or interrupt the instructions, and when this occurs, we typically refer to those as likely pathogenic or pathogenic. And in those scenarios where we're not entirely sure, based on specific criteria, typically those will be known as what's called a variant of uncertain significance, or a VUS for short. but we'll get into those later. The big takeaway is just that just because a gene is known to cause disease does not mean that every variant in that gene will cause disease. Each variant must be evaluated precisely, and essentially the labs classify these into precise 5 variants by what are called ACMG categories. So this 5-tier system, which you can see at the top of this slide, is a standard in genetic testing in terms of classifying variants. And while there are variations on how each lab interprets these from lab to lab, generally the standard is used from going from benign on the far left toward pathogenic on the far right there. The term likely, as in likely pathogenic, and likely benign are used when there is a high confidence, typically over 90%, one way or the other. A pathogenic variant means we are confident it causes the condition in question, and historically this was known as a mutation, but it's a more antiquated term at this point. Absolutely, yes. Sorry, I am a soft talker. Thank you. Where was I? So a benign variant is one known not to be disease-causing, also known as normal variation. The terms likely and uncertain indicate that incomplete evidence, essentially. So in other words, benign means the variant is not responsible for the disease, while uncertain means we can neither confirm nor exclude a role for that precise variant in disease. In practice, labs use many lines of evidence, including population data, computational predictions, and precise functional studies to apply these labels. So this slide here is a little bit small, so no need to read the precise details. But in short, this chart outlines the various levels of evidence used and their strength or weight of evidence that they provide to an overall interpretation. So these items include evidence like population data or absence of that variant in the population, computational models that look at how the protein may fold and the impact that may have on the overall expression of disease. It can also include things like functional studies, specific on a family, perhaps muscle biopsies, other imaging, and if a change segregates with disease in multiple families or otherwise. If you're interested in reviewing this in more detail, the ACMG and AMP have a great paper that goes into the technical details of this, so certainly let me know there. It's in the works cited as well. So getting into the different classifications, if a variant is classified as benign or likely benign, it means it is most likely not responsible for the patient's condition. Generally speaking, these are not included on most modern clinical reports, but for completeness, I wanted to address that as well. If your report says a variant is benign, we interpret that as this variant is not the cause of the primary disease indication, as we all possess these benign gene variations. We would then focus on other possible variants, genes, or diagnoses based on the specific indication. Next, we have a VUS, which is kind of what sits in the middle there between pathogenic and benign. And that means we do not yet have sufficient information to know confidently if that precise variant plays a role in causing the disease. There either may be not enough research or evidence, or the data we have may be conflicting in some manner. Having a VUS generally increases in likelihood as the number of genes analyzed increases. So a small panel looking at a few number of genes would have a lower likelihood of showing a VUS versus a larger test like a whole exome or a whole genome test, which is a much broader test, would have a higher likelihood of showing one of these VUSs, which is one important point with pre-test counseling to understand the risks associated with this given the lack of clarity. But in short, importantly, we cannot base major medical decisions typically on a VUS, given there's that lack of clarity, though some providers may do so to some degree. For example, you may have a child whose muscle disease is clinically proven, but the only finding is 2 VUS. So we would continue to evaluate that child clinically, further evaluate those VUS, and then depending on what information we have, in some certain cases may evaluate for other genes or otherwise, but One strategy in terms of determining a VUS is testing parents to see how those variants are inherited. If both come from a single unaffected parent, that may add evidence for that variant being benign. However, if one VUS is coming from each parent, that may add evidence toward pathogenic, but given the different inheritance patterns and gain of function and loss of function in RYR1, it's not super clear cut in that space. It's very precise to each individual family and the variants that are identified. So basically, in terms of management, it can vary there. Lastly, pathogenic or likely pathogenic variant means we are confident that this change causes the disease, with the likely piece meaning 90% versus pathogenic. We are very confident there. When we see a pathogenic variant that effectively confers either a molecular diagnosis or at minimum a carrier status based on the specific change of function with that variant. This then also provides actionability or the ability to take next steps from this information. The clinical team would then be able to counsel the family about that specific disease and plan therapies accordingly, as well as possible medical precautions. Additionally, we would then offer genetic testing for at-risk relatives based on the results, allowing informative results for the rest of the family. Essentially, in terms of negative results, they would then be at population risk. There's a nuance between what's called an informative negative and a non-informative negative, or a true negative. So essentially, when you have a true negative, when we're searching for a specific variant, if we find lack of that, it gives a higher level of confidence, whereas if we don't have a specific variant we're looking for, it's not as informative. So in addition to each variant, strength or risk, it's also important to understand how a condition is inherited, as this allows for appropriate risk assessment for both recurrence risk and future family planning, which are defined as inheritance patterns. There are various ways a condition can show inheritance patterns, but to keep things brief, especially given we already reviewed this in previous presentations, the most applicable ones are autosomal dominant inheritance and autosomal recessive inheritance. Particularly with RYR1, both of these can be expressed, but the specific circumstances with each variant and family are important to pay attention to here. So with autosomal dominant, this is essentially where generally an affected person has a single copy of a disease-causing variant that is sufficient to express disease, despite having a second functioning copy of the gene. They also possess then a 50% risk to pass along this variant, and then that child to express disease from that. So you can see this highlighted in the diagram here, where you have an individual who's shown in green that carries a single non-functional copy of the gene, as well as a functional copy of the gene, and then two of their four, essentially in probability, children would have this condition. And again, probability is with each pregnancy, so this would be 50% risk each time there. Next, in autosomal recessive inheritance, both copies of the gene must possess a disease-causing variant in order to cause disease. This was reviewed a little bit earlier, so just to keep things brief, essentially, each child in this scenario would have a 25% chance to be affected, a 50% chance to be a carrier, and then a 25% chance to not be a carrier or affected. In practice, essentially, this provides, each case is applied specifically with the report in hand. So it's applied with using things related to family history, the historical clinical data, and said report there. So now putting all these concepts together, next I'd like to review a little bit about the actual genetic testing reports. So given the lab used, they vary in format. So rather than sharing a specific lab report, I'd like to highlight the key points on each. So on all reports, it will list any variant identified, typically either a variant of uncertain significance, a likely pathogenic, or a pathogenic report. And it include that specific risk assessment of VUS, likely pathogenic or pathogenic. You might see something like RYR1 C dot 1234 A to G, or 1,234, so the location there, and then heterozygous, classified as a VUS. So what this means is at DNA position C dot 1234, and adenine was changed to a guanine, which is the nucleotide change that results in a lysine to arginine amino acid change, which are, again, those building blocks of the protein. Heterozygous means one copy of the gene has this change, while the other is not affected, unless there's another line on the report stating a specific additional variant there. The critical piece in this classification example here is that this is a VUS. If this was, or a variant of uncertain significance. If this was classified to be pathogenic, it would say pathogenic in this space. So while reputable labs will use that five category ACMG list, there can be a variation from lab to lab, as I mentioned, which is why it's still important to have a physician or genetic counselor review the report to make sure that the nuances are identified there. On these reports, in addition to that basic information, many will provide things like population frequency, predictive algorithms, as well as functional lab studies, previous case reports, or other evidence that may contextualize the report and why they classified it as, say, a VUS versus likely pathogenic versus pathogenic. And then lastly, these reports will typically go over things related to if there is a pathogenic change, what next steps to take, or other details on inheritance patterns. In cases where there's no variants found, typically they will list negative or no variants identified on the report. There's some nuances based on the type of report that comes out, but typically we'll state something to that degree. So now to tie it all together, I'd like to review a case. So this is technically a fictitious case, but just to go over the concepts, I think they're applicable here. So in this scenario, we have a 32-year-old woman with a mild history of proximal muscle weakness since adolescence and had one prior episode of unexplained postoperative hyperthermia. She showed or noted symptoms of occasional cramps, fatigue with exertion, but no respiratory involvement. In terms of family history, her father had experienced some malignant hyperthermia during childhood surgery, but there's no other known history of myopathy in any other relatives that was noted. In terms of genetic findings, the testing that was offered was whole exome sequencing. So this is, again, a broader test. There are more narrow tests in terms of panels that look at a curated number of diseases related to a specific disease indication, whereas whole exome sequencing is much more broad. And when doing a broader test, the likelihood of having unclear results does increase. But the trade-off there is it's, again, by testing more broadly, it gives ability to test many genes at once rather than in a stepwise fashion. In doing so, two RYR1 variants were identified. The first is a well-characterized variant that was classified as pathogenic. So just to kind of highlight how these variants are noted on here, we have the C.7300 G to A. So that's the location where the change in the DNA occurred. That confers a change in the protein from an arginine at the 243 location here to a histidine. That actually changes the actual shape of the protein, and in doing so, impacts the function of the gene. There can be different types of changes to genes, ones that cause gain of function, where there may be leaky calcium that can increase that risk for, say, malignant hyperthermia, versus typically more in recessive cases, but not always, in those that are a loss of function, where we're losing the function of the RYR1 protein. So there comes in some nuance there. But in this case, this specific variant has been reported prior in terms of MH and central core disease. However, a second variant was identified in, again, the RYR1 gene that had not been previously characterized. And on the report, the lab provided why they classified this as a VUS. So these bullet points down here are, so there's these codes here, say that PM2 and PP3, these are basically moderate versus supporting evidence and other lines of evidence utilized that they were able to identify on this variant. Specifically, they found that this variant was not observed in population controls. And then additionally, on computational models, they were able to identify that this protein change would likely have a deleterious or a damaging effect on the protein. However, the evidence below here are things that were not identified, and again, we need a high level of confidence when we're classifying these variants. And precisely with this one, they were not able to identify any previous case reports, any functional data, so any published assays that have been done specific to this variant, or other families where they were able to basically segregate this specific variant in the family where there's a specific inheritance where we're seeing, okay, individuals with this change are showing symptoms. So what we did in reference to this in terms of next steps is phase determination. So basically determining if both of these variants were inherited from one parent or one from each parent, or de novo, meaning a new variant that was not inherited. And in doing so, we identified that these are in trans, meaning one is coming from the father and one is coming from the mother. The father, again, who had a MH history, was found to have that well-characterized variant, whereas the mother was noted to have that VUS. Again, she did not denote any symptoms. So kind of the nuance here is that this pathogenic variant possibly explains that malignant hyperthermia in the patient we saw. But the history of any myopathy is not really determined as of yet. So really the clinical impact of that is we continue over time basically and revisit this VUS to see if it's reclassified, if it can impact care at a later point. We could additionally test other family members to see if they also carry any of this history, but again, there was limited reports of that in the history there. So all said, interpreting the results correctly is crucial for patient care. A pathogenic finding with an appropriate inheritance pattern can provide that clear diagnosis, whereas a VUS is one of those where we require additional familial testing or follow-up or additional data to really clearly say that this is causative of disease. When there is an appropriate diagnosis that allows for more precise information for management, whereas with a VUS, that management really has to be cautious at best. For family members, additionally, when we have that diagnostic pathogenic result, this can also provide testing for other family members there. Again, if testing is fully negative and a panel is performed, there are broader tests that can be done, such as whole exome or whole genome sequencing that provide a larger net. But again, it depends on the specific indications there. So in summary, it's important to understand the various reporting categories for the lab and how they vary in terms of strength, evidence, and actionability. Again, just to highlight, pathogenic variant provides either a likely diagnosis or at least a carrier status, depending on the specific variants there. A VUS, or variant of uncertain significance, means there's more evidence that is needed, and there's lack of a definitive answer at this point. And then again, the benign means that it's a negative result, and generally further investigation is needed. The takeaway really is just, genetics is evolving. We're still learning more, so it's important to revisit VUSs over time as more evidence will be gained from there. All said, I wanted to thank you all for inviting me to speak, and happy to answer any questions.
It's not working because I want to ask a question. Maybe, can you comment on how often you see reports patients have received themselves from private genetic services without counseling?
Yes, that's a great question there. So we'll certainly see a lot of folks who will either have, direct-to-consumer testing, where they can seek testing without having a clinician involved. I would say that occurs perhaps almost weekly at least one or two cases, not specific to RYR1, but certainly folks coming saying that they identified something on this report, and many times will help facilitate clinical grade testing where we're actually having a clinician involved, and those labs need to meet what are called CAP and CLIA requirements there. So they're a higher tier of analysis rather than using potentially just automated tools. And in those cases, a lot of the times those variants we identified, we don't identify anything of concern, but at the same time, there's been a few cases where we've actually identified something of concern. So it's the direct-to-consumer testing can be distressing to families at times just because there's a lack of information in terms of what the results mean and a large amount of information. So it's important to have appropriate clinician involvement just to make sure that there's clarity of what those results mean. There's always a lot of data, but it's making sense of that data, which is the challenging part. Thank you. Of course.
Any other questions? We're gonna not do the Q&A at the end since we're doing the Q&A immediately after and we're a little off time here. So if anyone has any other questions for Andrew, please speak up now. Oh, come on up.